I couldn't resist the opportunity to get dressed up today. We titled this program, MS is Not So Scary. And really what I want to do is give you some hope. I get a lot of questions on patient visits about repair and regeneration. Obviously, a lot of the visit when we have patients now is focused on modifying the disease course of MS. We utilize medications that modify the course, sort of slow down the immune system, or in many cases, completely shut it down. But we're on the verge of a revolution. We're moving into an era of exploration in the field of repair and regeneration, repairing the damage that has occurred and regenerating nerve tissue with the hope that maybe we can restore function and wind back the clock. What I'm going to do in terms of the outline for the talk today, I'm just going to get you under the microscope. We're going to discuss what a neuron is and what an oligodendrocyte is and what their relationship is, because these are the two main targets of repair and regeneration. And I'm going to talk about repair and regeneration of myelin, which is the insulation around wires. And that's focused on the oligodendrocyte. And I'm going to talk about two medications which have entered into human trials: Clemastine, which is an antihistamine, and Opicinumab. These are always tongue twisters. This is a monoclonal antibody, and we'll talk about that. And then I'm going to focus on the neuron and talk about repair and regeneration of axons, and we'll talk a little bit about Elezanumab. All three of these have entered into human studies. So what I'm going to do is I'm going to kind of show you maybe some cell culture studies, some animal models, and some human studies so that you can leave here understanding where we are. Now, for those of you like myself that are animal lovers, I will show some slides from mouse models, and yes, we advance medicine by involving mice in experiments and unfortunately sacrificing them and using their tissue to put it under the microscope. So just as a forewarning, I will show some pictures of studies done in mice and mouse tissue. So let's get under the microscope and talk about the basic unit of nerve cells within the brain. We have the neuron. The neuron forms the gray matter of the brain. They're on the surface of the brain. They're also located in deeper areas of the brain as well. Any idea of how many neurons we have in our brain? How many are we born with? Rough estimate? 100 billion. 100 billion neurons. Quite a large number. All right? And we also have neurons in the spinal cord. So to control any muscle, there's two neurons involved. The signal starts in the brain, and then the neuron conducts its electric current along this axon, which is a long arm. And an axon on the surface of the brain, the neuron, even though it's microscopic, its axon could go all the way down to my lower spine and connect to a neuron there. So or it could go to the cervical spine, and there's another neuron there, and it has an axon that goes out to a muscle. And so the neurons in the brain is where the electric signal starts. It sends a charge down to a neuron in the spinal cord, and that neuron sends a charge out to the muscles in our body. So it's pretty amazing. These things are microscopic, but these axons go a long ways. If you think about a microscopic body here on the gray matter, it could go as far down as my lumbar spine, and then there's another axon there that goes out to the sciatic nerve all the way down to my calf muscles. So there's two neurons. Now, in order to conduct an electric current, you can't just have a wire. You have to have insulation around it, right? Yes. And that's what the oligodendrocytes do, the blue cells here. The blue cells are partners with the neuron, and they have arms. And they send out arms, and they produce myelin, and they wrap around the axons. And any oligodendrocyte may send myelin out to several axons. And it's like an onion skin. So it kind of wraps its arms around it, and it provides the insulation for the nerve cell. There are oligodendrocytes obviously in the brain, oligodendrocytes in the spinal cord. There's oligodendrocytes in the optic nerve. There's axons. The optic nerve is basically just 10 million axons. All right? So the optic nerve, which is transmitting signals from my retina back to my brain, is a bundle of 10 million axons, and with oligodendrocytes wrapped around it. So we're going to talk about the neuron, regenerating and repairing the neuron, and we're going to talk about regenerating and repairing the oligodendrocyte. So we know in MS, for example, that in many cases the immune system misrecognizes the blue probably here, wrapped around the axon, is being foreign material, and periodically the immune system attacks it and chews at it, and it creates a sort of missing areas of insulation. So if I was to take this microphone wire right here, take a little pocket knife, and if I just nipped off a little piece of insulation, even though it's a tiny segment of this cord, it can't conduct an electric current, my microphone dies. Some people may wish that happens before I end, if I bore you. But it's incredible, right? When you think about an electric current, just a tiny piece of insulation missing can't conduct an electric current. So in MS, we know that when people have relapses, in many cases, there's a population of axons that get denuded of the insulation. So think about patients. Many of you probably had optic neuritis. You've got 10 million axons in your optic nerve, and any attack, maybe a million axons, or the oligodendrocytes, the lining of those million axons, is attacked by the immune system. And we do know that some people get better after relapses, not always, but sometimes. Why is that? Well, that's because some of us can regenerate myelin. Instead of it wrapping around the nerve, and I'll show you some electron microscopic pictures, instead of it wrapping around the nerve 30 times like it normally is, it may only wrap around 7 or 8 times, but it's enough to restore the insulation there. But one of the areas that's being looked at now is repairing the myelin. Can we repair the myelin? Can we create new myelin? So Clemastine is an antihistamine drug. It's actually, have you ever heard of over-the-counter Tavist, Tavist D? It's in Tavist, all right? So it's an antihistamine drug, but we think that it primarily, it probably doesn't work through its antihistamine capabilities. People here have taken antihistamines, right? What's the one thing you see on the package? Don't drive, may make you drowsy, right? And that's because all antihistamine products have a little bit of what we call anticholinergic properties. There are the cholinergic system is spread throughout the nervous system. If you were a tough crowd, I'd get nervous, I'd get sweaty, maybe I'd get clammy, my blood pressure might drop. That's all the cholinergic system. When the cholinergic system comes on, it's kind of the opposite of adrenaline. It also moderates pupillary size, and so it's part of the autonomic nervous system. So many of the cells in our body have cholinergic receptors on them, and all antihistamines also have an ability to block what we call acetylcholine receptors. And it's thought that the antihistamine property, where it blocks acetylcholine receptors, or anticholinergic properties, stimulates oligodendrocytes to create more myelin. All right? So there's this innate ability, believe it or not, these oligodendrocytes, we tend to keep them under control. Our body tends to keep them under control. Why don't we want oligodendrocytes overproducing myelin? Because guess what? It could result in tumors. All right? So if I gave everybody magic drugs, stimulated all the oligodendrocytes, it might create things like gliomas. Gliomas are, you may have heard of glioblastoma multiforme, a terrible brain cancer. That's oligodendrocytes gone wild, immature oligodendrocytes dividing and dividing and dividing. So this is really the first study published in 2014 by a team. And what they did is they are able to culture oligodendrocytes in a petri dish, and they exposed the oligodendrocytes to a variety of medicines to see if they can find a hit. You know, that's how pharmaceutical industries create new drugs. They have these cultures, and they theorize which drugs are going to work, and they apply thousands of drugs, and they get a hit, and then they continue to develop. Well, they did find a hit with Clemastine. And this is the cell culture with the green dots on the left representing very immature oligodendrocytes, kind of baby oligodendrocytes that haven't really created a lot of myelin yet. And the red stain represents what we call myelin basic protein, obviously a big component of myelin. So we have stains for myelin basic protein. Here's cell culture A up above. A little bit of red exposed just to like saline drops. And C is oligodendrocytes exposed to Clemastine, baby oligodendrocytes, And this is kind of if you cut them right in half, and this is if you cut them this way. And look at the big difference in the number of red spots over here and the number of red threads over here. So it stimulated these immature oligodendrocytes to produce myelin. We go from cell culture, we go to animal models. You know, if it works in cell culture, maybe it'll work in an animal model. And yes, this is a mouse model. It does require sacrifice of the mouse, unfortunately. But there are ways of inducing sort of MS lesions in mice when we give them a drug called lysolethicine. And this is their spinal cord of a rat transected this way. And if you see the black, this is the normal gray matter. These are those neurons that I told you about, all right, in the spinal cord. This is the axons down here, the white. But notice these black holes here, here, and here in 3 spots. The drug has kind of demyelinated it. It destroys the myelin on axons. And then these mice were treated with oral Clemastine, and after 14 days, their spinal cord was, they were sacrificed, and the spinal cord was put under microscopes. And in the middle, the blue dye just is dyeing the unmyelinated fibers. And you can see many more myelinated fibers, less blue in the Clemastine-treated mice. And then when you put it under the microscope and do electron microscopy, these are all nerves, axons, and the black is myelin. And look at how many more axons have myelin around it, and it's thicker, all right? So the Clemastine, cell culture stimulates immature oligodendrocytes to produce myelin, and then when we give it to mice in sort of an MS model, we see more axons that have myelin, and the sheaths are thicker when they're there. So where does that bring us now? Well, we do have a human trial that's been published, and this is in 2017, only 2 years ago. It was called the REBUILD trial. Phase 3 trials are the big trials. Those are the ones where we put many people on placebo and many on active drug, and the main outcome is how does it affect the disease course? Does it work? Many of you are on drugs for your MS, and they were FDA approved based on phase 3 studies. Sometimes the FDA requires 2 phase 3 studies. In rare cases, 1 phase 3 study. Phase 2 studies occur before phase 3 studies. And what phase 2 studies are, they're designed to assess safety. And obviously, we have to be sure that any medication we use is safe. But they do also gather some information regarding efficacy. Does it work? So efficacy is a secondary outcome. If the drug's perfectly safe, but nobody gets better, it probably won't go to a phase 3 study. But if it's safe and we see sort of an inkling that, yes, patients are getting better, it will go to phase 3 studies. So this is a phase 2 study. It was double-blind, placebo-controlled, which means neither the patient nor the treating physician knew if the patient was getting the placebo or the real drug. It was done at a single center, University of California, San Francisco, which is an excellent medical center, and they found 150 patients, and they limited it to patients who had optic neuropathy in the past. So they had an optic nerve that had been damaged. In part, it was demyelinated, and obviously these patients had to be on an immune modulating agent as well. And in these 150 patients, the mean time since their optic neuritis occurred was 4 years prior. So these are patients where that optic nerve is demyelinated in part, and it's likely at a point where it's not going to recover at a mean of 4 years out. And the dose that was given was 5 milligrams twice daily. Now, if you look at Tavist, I think Tavist is 1.25 milligrams, and it's recommended to take it twice daily, I think maybe 3 times. So this is 10 milligrams. It's about 2.5 to 3 times higher than the dose that most people take this drug at. And the primary outcome, in other words, the measure in this phase 2 study, was what we call shortening of the P100 latency on the visual evoked potential. Now, what is that? Well, some of you may have had visual evoked potential, especially those that may have been diagnosed 20 and 25 years ago. We do it less frequently now. Our optic nerve is a big wire, and anytime we stimulate our vision, the retina senses it, the cells there generate an electric current, it goes back through the optic nerve to our brain where we process it and interpret the image. In most VEPs, if people did it, you may have seen a checkerboard pattern. It kind of weaves and waves, and we have electrodes at different points, and we can measure the current as it goes all the way to the back of the brain where we interpret it. So the P100 measures the velocity of that current. And in people with optic neuritis, obviously it's going to be a little bit longer. The normal P1 latency, that's the time it takes to get through the optic nerve, is about 90 milliseconds. So in this study, there was a modest improvement on the transmission of electric signals in the optic nerve in those with MS that had optic nerve damage. It reduced the latency delay by about 2 milliseconds per eye. Remember, the normal is 90, so it's not a gigantic change, but it is a change. And that was statistically significant. Now, again, this was a phase 2 trial, so we want to be sure that giving higher doses didn't make people pass out, get goofy, hallucinate, have a Woodstock experience. Maybe looking at me, you're all having a Woodstock experience, because I don't look like this in the office. But it was safe. There were some people with fatigue, and, increased fatigue. Yes, antihistamines. I get fatigued if I take an antihistamine. So that was only the side report. And the authors concluded that our findings suggest that myelin repair can be achieved even following prolonged damage. So you can sense, yes, there was some remyelination there. Now, as far as I know, this is being potentially targeted for phase 3 studies in humans. I'm not aware of a study right now that's recruiting, but I want you to stay aware of this compound, okay? So Clemastine is an area that's being looked at right now. Now we're going to move into what we call monoclonal antibodies. There are probably patients in the audience that are on a monoclonal antibody. So monoclonal antibodies in use in multiple sclerosis are Tysabri, Ocrelizumab, and Lemtrada. These are proteins. They're shaped like a Y, and I'm not going to do the YMCA dance, but they are targeted to one specific protein in our body, right? Tysabri locks on to a protein on the outside of T cells, white cells, and prevents that protein from adhering to the inner lining of blood vessels of our brain, opening up a passageway to get in the brain. So it kind of like puts a glove over a key on the T lymphocytes. All right. So monoclonal antibodies are one of the incredible discoveries in medicine that really has come into use in the last decade or so. Scientists are looking at utilizing monoclonal antibodies to stimulate oligodendrocyte repair of myelin. Now, as I mentioned before, we do have an innate ability to create myelin, but our bodies generally shut the majority of that off to prevent tumors from forming. All right? So there is a receptor on the surface of oligodendrocytes that's called LINGO-1. And LINGO-1 stays active all the time, and it suppresses the ability of the oligodendrocyte to manufacture myelin. All right? Now, if we block LINGO-1, oligodendrocytes can create myelin. So how about if we create a monoclonal antibody that finds LINGO-1 in our body and it latches onto it? And that's exactly what Opicinumab does. All right? It's an inhibitor. It inhibits LINGO-1. Thus, it allows oligodendrocytes to kind of become creative and create more myelin. And this is an animal model, a rat model. One of the big models that's used in animal studies of multiple sclerosis is what we call experimental allergic encephalomyelitis. Again, another mouthful, but basically what that is that if we inject mice with myelin basic protein from another mouse, the body feels like it's a foreign protein, right? And the body, as it's attacking that myelin basic protein floating around in the bloodstream, there's accidental bystander effects in the brain and spinal cord and optic nerve of that mouse, so they get MS-like lesions. All right, and this is how many drugs are tested in animal models of MS. Opicinumab has been tested in a mouse model of experimental allergic encephalomyelitis. And this study was published a decade ago. If you look at the top on A, we have a normal mouse, optic nerve, and there is a clamp model of, to induce some damage of an optic nerve. What they do in these mice is they make a little incision, and they take a little clamp, like just a forceps, and they squeeze the optic nerve for 10 seconds and then release it. But that's enough to cause just axonal mechanical damage to the axons. It doesn't impede the blood flow, so it's not like a stroke in the optic nerve. It just damages the axons themselves. All right? And axons die back. So if this is an axon going out and I clamp it here for 10 seconds and it damages it, it's going to die back. All right? And then we have the experimental model whereby if we give that mouse a drug, we can then later on, I'll use the term ethically sacrifice the mouse. They do put eye drops to prevent eye pain, and ethically sacrifice the mouse. We can look at the optic nerve and see if myelin has been regenerated. So this is an example of a mouse. If we look on the far left, that's a normal nerve. In the middle, you can see that gray nerve. That's just a control mouse, not treated. And on the far right, we can see, I think it's a month out, we can see an optic nerve in a mouse that's been treated with Opicinumab. And you can see that the optic nerve looks pretty darn normal. And when we put it under the electron microscope, here's the normal nerve. You see the myelin around the nerve, that black, the black structures around the nerve. Here's the mouse that was not treated. You can see the nerves, the axons, but there's no myelin around them. And then the rat got Opicinumab, and guess what? You see myelin wrapping around the individual nerves. Again, remember, there's 10 million nerves, axons, in the human eye. I don't know how many are in the rat, but many of the axons became remyelinated. So by blocking that anti-LINGO, we can say that the oligodendrocytes are like, the parents are away, let's have a house party, let's start myelinating again, all right? So there is a human trial, and this was just published, so we timed this very well. And this is a phase 2 study called the Synergy trial. This is a drug which is administered IV. The Synergy trial was a phase 2 study, so again, mainly safety. And it was 2 doses. It was a randomized double-blind study. Again, some patients get saline, some get the real drug. Patient doesn't know. Treating doctor doesn't know. And there were 4 dose ranges. We see that in phase 2 studies because we try to figure out which is the best dose. And there were 419 patients with relapsing forms of MS enrolled at 72 sites in 12 countries. All patients also received interferon beta 1A. It would be unethical to do a trial like this and not be on an approved drug. The primary measure was the percent of participants achieving confirmed disability improvement. All right? So we have various scores where we assess patients, and some of you may have participated in clinical trials, and we often do what we call the EDSS. We do the physical exam, watch you walk, check your vision, and we assign a number. In these studies, we're looking at how many improved, right? You're remyelinating, you want to see how many improved. And here's the outcome chart. What we see here is on the bottom, we see 4 different doses ranging all the way from 3 milligrams per kilogram up to 100 milligrams per kilogram. And on the top of this dotted line is, patients that improved, and below are those that were worse than placebo. And we certainly, the red dot is kind of the average. And when we look at the bars above and below, that's sort of statistical significance. So what we do see at the very lowest dose, there was no difference between placebo and active drug. And we do see a little bit of a benefit in the 10 and 30 milligram per kilogram doses. We see kind of paradoxically maybe it's no difference in the higher dose. All right, so we have a little ray here of hope that maybe this dose, and again, these are short studies. You know, this is done over a year, I think. And we have a little ray of hope here. Now, the authors, many times what you like to see in these phase 2 studies is you increase the dose. You know, things should get better and better and better, or they should get better and then kind of level off. It was a little perplexing that it kind of went up and then kind of came down. What they concluded was that further studies are needed to investigate whether some subpopulations in this study might benefit from the drug at an optimum dose. So what they're suggesting here is that all comers with this drug, in other words, when you do a study like this phase 2 study, you have all comers, patients of different ages, different disease duration, different findings on the MRI. They did a sub-analysis in this study and looked at various categories. It was small numbers, but they did find that patients who had a baseline thalamic volume, the thalamus is the deep gray matter area in our brain, and we do know that in some patients who have more progressive features of MS, it tends to shrink because they're losing neurons. They did find that those patients that had larger thalami than the mean did very well. They also found that via measures of brain volume, that those with the smallest brains, again, which can be a progressive feature, tended not to respond, whereas those that had larger brains responded. So I think what we're going to see with this is that we're going to probably see them do phase 3 studies, maybe selecting certain subcategories of patients with MS who are most likely to respond to the therapy, and we'll see where they go from there. Now let's move away from myelin and talk about axonal regeneration. This is sort of interesting. So in MS, we talked about myelin wrapping around, you know, this axon here, and after a single demyelinating event or multiple demyelinating events, if people don't repair that myelin, the axon itself is exposed to the environment. So it's like me walking around for a year with an exposed wire here. There's copper in here. What happens to the copper? It turns green, and eventually it kind of starts to decay, right? So that's what happens to exposed axons in MS. The axon itself starts to decay. Well, one avenue of thought here is, what if we can stimulate that neuron to recreate an axon, to grow another axon? All right, before we were talking about wrapping the insulation around, now we're talking about regrowth of axons. And there is a drug, a monoclonal antibody. I love this thing that it inhibits. Isn't this a great term? It inhibits a protein on neurons called repulsive guidance molecule. How about that? Let's get rid of that repulsive guidance molecule. All right? And we don't want, normally, you know, we're born, believe it or not, we're born with 100 billion neurons, unlike our bones, which grow. And, you know, we create more bone cells, we create more skin cells. We don't create more nerve cells. We're born with all our nerve cells. Obviously, the axons get longer as we grow older. But we don't create new neurons. All right? And it's in part because of this repulsive guidance molecule. Again, if neurons went wild and divided and we created new populations of neurons, you know, that's where we get tumors. So we have this innate natural ability to inhibit neuronal regeneration. But if we can selectively block one of the molecules involved in that, we may be able to enhance axonal regrowth. So in animal models, this drug was able to promote repair of axons and even protect it against damage in, you know, experimental allergic encephalomyelitis type models. And here's that optic nerve model that I showed you before. And this is a study this is animal models published just 4 years ago. And imagine this is the optic nerve kind of transected right through the middle. It's running this way. Here's a mouse after 6 weeks that got just saline. Green represents new axons that have grown out along the nerve. All right, and this is near the retina on this side, and this is the retina over here. This is kind of back where the optic nerve enters the brain. So you can see that the control has very little bit green, very few new axons, whereas the mouse that got the Elezanumab created new axons that sprouted out. So there are, I want to let you know that there are 2 trials now going on with this medication, Elezanumab. This is a phase 1 study. It was a safety study that involved people with secondary progressive MS and relapsing MS. They got 4 doses of the drug over 4 weeks, so it's just a 16-week study. We're looking at safety, right? If everybody develops atrial fibrillation, passes out, bad stomach pain, vomiting, we're not going to go further, right? So these phase 1 studies tend to be very short, and there were 20 participants. It was well tolerated, and it did not cause any unusual abnormalities in the brain. In other words, we didn't see tumors growing or inflammation in the brain. This is there are 2 phase 2 studies going on now with this drug, which are looking at it more globally and in a bigger population to assess the safety and also to gather efficacy data. Patients will be treated for a year with the drug in this study, and it's again double-blind, placebo-controlled, 165 participants. The study started enrolling patients nearly a year ago. It's expected that we will know the results within 16 months in this study, and the primary outcome measure again is looking at disability scores to see if there's improvement. Now, for those with a progressive form of MS, they're not being ignored, right? For progressive MS, we know that they're probably, in people with relapsing MS, demyelination is the big theme. In people with progressive MS, axonal loss is the big theme. So the progressive population is not being ignored here. And there is a similar study going on with 90 participants who are receiving this drug over a year. And the first patient was enrolled in January. And again, we'll know probably in June of 2021 regarding the outcome from this study. So 1993 was a remarkable year. It ushered in the year of therapy. It was the beginning of the era of proven therapeutics for multiple sclerosis. Here we stand 27 years later, and I can tell you that we have entered into the era of evaluating drugs that may restore and regenerate the central nervous system in clinical trials. All right, and I'm optimistic that we're going to find something. And one thing I want you to take home is that you can see that we're looking at 2 angles. One is repairing myelin and regenerating myelin. The second angle is regrowing axons. All right, and we've entered into the era of human clinical trials in both of those arenas. So it's a real exciting time. I'm hoping that in the next few years I can put another bullet below that and say, 2020, 2022 or 2023, era of regeneration and restoration. There's a wonderful website that you can explore, www.clinicaltrials.gov. It's meant for the public to access, and it's pretty easy to use. There's 4 bars. You can put in multiple sclerosis in bar 1, and then you can put these drugs in bar 2, and it'll pull up all the clinical trials going on, show you what the criteria to get in is. It'll show you the enrollment update. It'll talk about the abstracts that were announced at scientific meetings and publications. And use that site. You can explore other things with MS therapeutics. It's meant for the public to access. So it's www.clinicaltrials.gov, G-O-V.